Welcome to Indian School of Urology Smart Learning Program for residents and consultants. And today it is my proud privilege to introduce Dr. Abhishek Singh, though I know he doesn't require much introduction, especially in the younger crowd. And he is right now the president for the youth section of urology, and also he's a consultant at Muljibai Patel at Nadia, and plus he is on the editorial board. He's of IJU, and he's a very active and academically inclined. And I'm very proud that he graduated from KM Hospital, Mumbai, and it's my this webinar was with the youth section. I hope many more of the youth section members join, as this is a topic which will be of more of use to you in the future rather than to our generation. uh, and I hand over the proceedings to Dr. Abhishek and Dr. Siddharth to carry over.
Thank you very much, madam. Thank you, ISU, for this wonderful opportunity. From the YOU side, Dr. Siddharth Yadav, who is the associate professor at Safdarjung Hospital, would carry over the further proceedings. Over to you, Dr. Siddharth.
Good evening, sir. Thank you, ma'am, and thank you, sir, for giving me this opportunity. So today's topic is about ergonomics, and as we all know, it is a very, very important thing. So as ma'am has already said, we will be discussing about the ergonomics for both the laparoscopic surgeries as well as for the robotics. And this is primarily important for younger people because if they learn the right things right now, they can improve upon their stance and other things. So the first presentation will be by Dr. Abhishek Singh himself, and the topic will be ergonomics in laparoscopic urology. Sir, over to you, sir.
Thank you, Siddharth. I'll share my presentation. So I hope my slides are visible. So what are my slides visible, and am I audible?
Yes, sir, clearly audible.
In the next 20-25 minutes, we shall discuss about ergonomics in laparoscopic surgery. As important it is to do a laparoscopic procedure, even more important is that you learn it quicker and survive the aftermath of doing laparoscopy. A good ergonomic placement of yourself, your operating room, and all the ancillaries will help you get around these problems. So that is the basis of the coming talk. I have nothing to disclose. Laparoscopy started very, very early when basically they wanted to counterfeit the problems of portal hypertension. The patients with ascites, they thought if they put in a patient of portal hypertension, if they create pneumoperitoneum, the portal pressures will go down. This was their initial theory. And they tried doing this with patients of portal hypertension to no avail. And then in human experiments, after the initial Killing's dog experiments led to start of laparoscopy. The laparoscopic procedures in urology started very late, with the first procedure that Dr. Ralph Clement demonstrated being a radical nephrectomy in a 80-year-old female, which came about after 5 porcine experiments. And the histology of that nephrectomy specimen was an oncocytoma, which clearly was an overkill in today's times. But nevertheless, it set the ball rolling. It is said that laparoscopic urology was extremely slow to grow because the learning curve was slow, the optics were poor, the vision was haptics were lost, and there were very few urological procedures which required laparoscopy as compared to gynecological or general surgical procedures. But all these arguments today are mere lies. Why do laparoscopy? We do laparoscopy because we see that laparoscopy gives us magnificent visualization. There's dramatic post-operative recovery. Wounds are smaller, and everybody is involved in the procedure due to the courtesy of video imaging systems. So your operating room setup is your basis of initial basis of the ergonomic setup. So if you look at the components of an operating room setup, it includes the imaging system, insufflators, hemostatic generators, and instrumentation. So how do you set them up over a vision card? So at the highest level should be your monitor itself. The monitor should, the distance of the monitor from your eyes should be 5 times the diagonal of the length of the monitor. So for a 21-inch monitor, you should be standing 105 inches away. Just below that, you can have your camera and the light source. Immediately below that should be your insufflator and suction irrigation machine, and then comes the turn of electrostatic generators. So if you have the luxury, you can have 2 monitors opposite to each other. So for all upper tract laparoscopic procedures, it is a very good idea that the camera driver stands cranial to the operating surgeon. The only other situation can be that the camera driver standing caudal to the operating surgeon. This typically happens when the surgeon is doing an upper tract extirpative procedure and is doing right upper polar dissection. Apart from this, there should be no situation where the camera driver actually goes caudal. So for a convention, the camera driver stands cranial to the operating surgeon in an upper tract laparoscopic procedure. And the staff nurse or the scrub nurse should be standing at the caudal end, and the circulating nurse should be behind. Before anybody embarks on an operating procedure, laparoscopic procedure, we should make sure that the suction and irrigation are working. The electrosurgical units are fine and working. CO2 tank is full and there is an additional tank available. The camera is white balanced and the light source is working. The various tip should be retracted and the insufflation should be checked. If you have these bearings right, there will be a smooth entry into the procedure and your learning curve should definitely decrease. What are the general principles of operating room setup? The operative field, the surgeon, and the monitor should be in the same line. That is what it means that the surgeon is optically correct. The insufflator should be on the vision card, and the light source should also be on the same card. All the lines should be tangle free. The drapes should be such that they should be able to hold instruments individually without the crossing over of wires, preferably 2 monitors. This is something that you don't want to see in your operating room. I am trying to insufflate while looking behind. This, if I am a person who's just initiating the laparoscopic program, my Veris needle might get displaced into the subcutaneous tissue or go deeper if I do not concentrate or try to look behind and look at the insufflator readings. Laparoscopic drapes, custom-made drapes are extremely helpful. Gone are those days where we use some cloth which is stitched by a tailor and put it onto our drapes. If they keep dragging down, your instruments will keep dragging down, they'll entangle and create problems. These custom-made drapes are very cheap, about 500-700 rupees. There are holes in these drapes where you can park the wires, and there are about 4 or 5 pockets where all the instruments can rest and the wires remain tangle-free. It is worth investing in these drapes for a for an enhanced ergonomic experience. The operating surgeon and the assistant are like jigsaw puzzles. They should be able to bind into each other's habitus. If the surgeon is very tall and the camera driver is very short, the taller person can sit. And in any situation, they should try to match the habitus of each other. So taller surgeon, he can sit and operate, and the shorter surgeon can show the camera while standing, or vice versa. If the surgeon is short and the camera driver is tall, he can sit. The laparoscopic surgery is basically based on 3 important pillars: ergonomics, task analysis, and psychoengineering. So let us talk about the problems which have made ergonomics so important. Laparoscopic surgery predominantly gives you 2-dimensional vision. there's loss of depth perception. All instruments behave like levers. That means there is a fulcrum on which the instrument moves. Typically, all laparoscopic instruments have only 4 degrees of freedom movement. That means you can move in or and out. You can move either clockwise or counterclockwise. These are 2 movements. The third movement is if you move the handle down, the tip goes up, and if you move the handle right, then the tip goes left. So these are the 4 freedom of movements on which the entire laparoscopic surgery is based. What is important to note that out of these 4 movements, 2 are intuitive. That means the movement is as per your desire. That means if you rotate clockwise, the tip of the instrument rotates clockwise. And if you move the handle of instrument down, if you move the handle inside, the tip of the instrument moves inside. That means the in-out movement and the rotatory movements are intuitive. Whereas when you move the handle down, the tip goes up, and when you move the handle right, the tip goes left. These 2 movements are counterintuitive. So 2 intuitive and 2 counterintuitive movements help you construct laparoscopic surgery. Our belief is that predominantly laparoscopic surgery is counterintuitive, which is not true. The vision is not under surgeon's control. It is always controlled by somebody else. So to avoid the pitfalls of laparoscopic surgery, ergonomics are extremely important. Ergon means work and nomos means law of nature. So it is creating an environment where a man can work well, or making a man more comfortable to whatever he is doing. The ergonomics are of 2 types: sensorial ergonomics, which improve your precision, dexterity, and then physical ergonomics that give you more comfort, like appropriate working temperature, good light. So if you look at potential problematic areas, as compared to an open surgery, the freedom of movement is less in laparoscopy, and as we discussed, vision is not under our control. All movements work as per the lever principle. There is a decoupling of visuomotor axis. You have loss of haptics and loss of depth perception. There is a loss of peripheral vision also, because you have to maintain a static for a long time. There is fatigue. So to counterfeit all these problems, you require good ergonomics. So the principles of ergonomics mean the level of the instrument. The level of the instrument should be such that your elbow is nearly at 70 to 90 degrees to your arm. So this will create a good working environment for your hand. Manipulation angle basically is the angle between the 2 instruments. Ideally, this angle should be about 60 degrees. As this angle increases, there is a lot of abduction of the shoulders, and beyond 75 degrees, there will be significant abduction, and a person cannot work with this abduction for a long time. Azimuth angle is the angle that a laparoscope makes with an individual instrument. Ideally, this should be about 30 degrees, never less than 15 or 45. Otherwise, if it is more than 45, the shoulders will get abducted. If it is less than 15, then rolling over of instruments will occur. Elevation angle is the angle that an instrument makes with the horizontal of the body. Whenever it is more than 60 degrees, then there is a lot of abduction of the shoulder again. What it also means is that your instrument is too close to the target anatomy. That means you put the port very close to the target anatomy. So this is how your ideal angles should be. This is what should not be. Here the elevation angle is very high. The surgeon is looking towards a screen which is not incidental to his eyesight. The ports are very close to the target anatomy, and therefore the surgeon will not be able to carry on the surgery for a significant period of time. Now, all instruments behave like work on the lever principle. They basically behave like a lever. So there is a fulcrum, and then on which the instrument moves. The instrument that you hold, or the handle part of the instrument, is the load arm, and the tip of the instrument is the effector arm. Ideally, every laparoscopic instrument in an adult is about 36 centimeters. For translation of movement 1:1, that is, when you do a 1 centimeter movement outside, converting it into a 1 centimeter movement inside, the load arm length should be equal to the effector arm length. That means the instrument should be 18 centimeters inside and 18 centimeters outside. So that when you create 1 centimeter movement outside, it is exactly translated. What happens when more than 3/4 of the instrument is inside? When more than 3/4 of the instrument is inside, say you are doing a left-sided upper tract extraoperative surgery and you are working on the lienorenal ligament. Your right hand port is slightly lower. That means about 24, 28, 30 centimeter of instrument is inside and only 5 centimeters of instrument is outside. That means the load arm becomes small and the effector arm becomes long. That means for every unit movement done outside, the movement inside is significant. That means the effort is rectified and the movement is magnified. So if you are trying to cut the lienorenal ligament with a hook, your hook might wobble and hit the diaphragm, creating a rent in the diaphragm, which is not a good situation to be in. Similarly, there can be a situation where the instrument is or the target anatomy is too close to the target organ. Your port is too close to the target organ. Here, one thing is that there'll be a lot of abduction on the shoulder. The second thing is that your elevation angle will increase. And the third thing is if you're using a metallic port and using an energized instrument, your tip, the electrons of the tip of the instrument, say hook, will go astray and then will be conducted by the metallic port. And God forbid, if your metallic port is in touch with a bowel, it will cause bowel injury. This is called as capacitative coupling. So here what happens is the port, 3/4 of the instrument is outside and 1/4 of the instrument is inside. That means the force here is rectified and the force here is magnified and the movement is rectified. Another important ergonomical consideration is like what is seen here. Now, this is a picture of an optical illusion. Either you see a young lady or an old lady. If you are imagining this portion to be the chin, then this is a old lady. If you are imagining this portion to be the chin, then this is a young lady. So why I bring this up here? Because the depth cues are extremely important. And depth cues are maintained by having good ergonomics. That means once your optic is between the two working instruments, you'll get the best depth perception, best imagination of the depth cues, and thereby you'll be able to do a better surgery. Now, an expert surgeon suddenly goes and picks up a needle, whereas a novice will pass point it many a times before picking it up. Why does this happen? This happens because an expert over a period of time learns to interpret the depth cues. So here you see a needle which is in front of a chicken breast. The needle is occluding a part of the chicken breast. How do we know that? Because it is casting a shadow on the chicken breast. As the camera pans into the needle, the relative movement and size of the needle increase. The sharpness of the edges improves. The movements get enhanced. And the texture of the chicken breast, if you see again, would be more clearer. So these are extremely important things and depth cues. Because the needle is casting a shadow on the chicken breast, it is occluding a part and it is in front. As you move towards the needle, its size increases and the edges also become sharper and movement become more enhanced. That means something that is farther is darker, deeper, moves lesser, and the margins are not clear. Something that is closer moves more, is larger in size, and edges are more defined. So imagine a situation where you're trying to identify a renal artery. Intermittently, if you pan your lens inside, you will be able to see enhanced movement of the structure. So the summary of instrument characters is that it should behave like type 1 lever. That means half of the instrument should be inside, half of the instrument should be outside. This is practically impossible to keep inside 18 centimeters inside and 18 centimeters outside for an adult 36 centimeter instrument. So you should assume a distance between 18 to 24 centimeters. The telescope should be in between the working instruments. The angle of manipulation should be about 60 degrees. Elevation angle should be 30 to 45 degrees, never more than 60 degrees. The distance between the two ports should be about 7.58 centimeters, and azimuth angle should be about about 30 degrees. So if you look at ergonomics of port positioning, so imagine we just talked about a situation that 18 centimeters of instrument should be inside, 18 centimeters should be outside. So if you look at a triangle law, then if you want the angle between the two working instruments to be 60 degrees and assume a triangle law, that means you want to create an equilateral triangle which has each side to be 18 centimeters. 18, 18 and base will be 18. Now you want azimuth angle to be 30 degrees. That means you have to bisect the manipulation angle into two, creating two segments of sectors of 30 degrees each. That means the base, which was 18 centimeters, should be divided into equal 9 centimeters on both the sides. And the center point should be triangulated a little to get your perfect port position. This entire math can come true if you use a baseball diamond concept. That means you create a diamond out of your hand and place the summit of your middle fingers at the target anatomy, and your anatomical snuff boxes will both give the position of right and left hand port, and the summit of your thumb will give the position of the camera. So from tip of my thumb to anatomical snuff box is like 8 centimeters. And if you keep on increasing the size of the instrument, the arithmetic of triangle law will change. That means for adult instrument, it is 36 centimeters, half of it is 18. For a bariatric instrument, it is 42 centimeters, so half will be 21 centimeters. For a pediatric instrument, it is about 28 centimeters, so half will be 14 centimeters. And for an infant instrument, the same thing will be 21 centimeters. Another important concept is gesture imprecision. So your instrument size and your trocar size should match. That means you should use a 5 mm instrument through a 5 mm trocar only. Then only the instrument will not wobble. The ideal position of the surgeon should be that head should be relaxed. There should be no rotation of the trunks. Shoulder should be relaxed. Elbows should be at about 70 to 90 degrees. Forearm should be horizontal. A hand should be pronated. Grip on the instrument should be light. The table should be at the level of waist. Gaze should be down. Straight line principle should be obeyed. So as I told you, the height of the table and height of the surgeon should have a ratio of 0.5. Surgeon should be able to look down towards the monitor. A 20-degree downward gaze is a best situation. And the distance of the monitor from the surgeon should be about 5 times the diagonal length of the monitor. At this particular situation, the vision formation, the image formation occurs at the level of macula, and there is maximum acuity of vision. The illumination should be at least 20 lux in the OT. Another important concept is, which we'll briefly go through, is task analysis. This is stepwise deconstruction of task and the stepwise constitutional stepwise analysis. That means each procedure should be broken down into procedural steps and executional steps. Executional steps are small mini steps that help you form a procedural step, like port positioning. If you want to execute this, you must know that how do you hold the Veress needle, how deep should you go, how many clicks should you get, when should you aspirate, when should you do a hanging drop, what to do if you don't get a proper pressure sequencing, should you advance or back off. So when you arrange these executional steps in a particular array, then you get a one procedural step, and for every procedural step you do a small executional step. Like lifting ureterogonadal packet is a procedural step. You divide it into small executional steps, like identifying the ureter, a wide structure running craniocaudally, having fine meshwork of capillary, having peristalsis. Then you open the gerotas, anterior layer of gerotas below the ureter. Identify the psoas muscle from the medial edge to the lateral edge. Carry on this dissection from the common iliac till the appearance of renal vein. So if you know all these executional steps and you write this down for every procedural step, your surgery will be complete. Before you embark on any procedure, the learning that skill has three phases: cognitive, integrative, and automation phase. Cognitive phase is where you do everything tentatively. Integrative phase is you are doing something knowingly, but you are putting an effort, but you are still not very stressed about it. And stage of automation is a situation where you can carry out all the steps at spinal level. So you should train yourself in lab and put your ergonomics to a level where you reach a stage of automation, so that you are worried only about only about the problems of the surgery and not about basic cognitive skills. To learn any surgery, you have to, or to master it, you require 10,000 hours as proposed by Malcolm and Gladwell. So deconstruct the skill, put it into smaller steps, learn enough to self-correct, remove distraction and frustration barriers. Are we thinking about training the way people in other competitive sports are? So, so there are there are people who practice their art every day. We as surgeons who are doing extremely important work, do we practice our art every day outside the operating room? Is a question that we should ask ourselves. Practice isn't something that you do once you are good. It is the thing that you do that eventually makes you good. So 10,000 hours is the time that is required to master your craft. I think we should get started today. The effect of this 10,000 hours is so subtle that nobody, even your neighbor, cannot know it. So these are the hands of Dr. Arun Perwani. He told me that, see, Abhishek, look at my hands. These are the effect of 10,000 hours. And I was not able to identify what he was trying to tell me. He was only hinting at his hypertrophy of first dorsal inertia. So such is the subtle effect of 10,000 hours that it may go unnoticed on most occasions. I leave you with this last thought that top athletes and singers have coaches. It is high time that we should identify a coach. It is not necessary that that person should always be present in the operating room. It should be a mentor that we can often contact, discuss our problems with, so that whenever we land up in problem, or if we have had a difficult day, we can reach up to him and discuss our issues with him. This will just make everything more easy and will shorten your learning curve. So even if you have just started, your success is just around the corner. You just need to deconstruct whatever you are doing, put it into small bits, and you will be mythical. So my key message from this lecture is: the more you sweat in setting up ergonomics, the lesser will your patient bleed on the operating table. Thank you for a patient listening.
Yeah,
Thank you, sir.
thank you, Abhishek. Abhishek, I have one question for you.
Yes, sir.
What are
Yes,
the
madam.
tips you do when the patient is very thin and very hardly having any breath to the abdomen?
So, ma'am, the reference point for putting a first, let's talk about a left upper tract surgery, very thin patient. The reference point for putting his first port is midpoint of spino-umbilical line. So, your first port in a very thin patient should go down medially a little. So, if the BMI is like 17, 18, you should drop your reference point towards the lower limb and medially by about 1.5 centimeters. This will help you. And
Because
taking access in this patient is very, very difficult. That is the most difficult part. So you should not wait for, when you're putting the Varies needle, you should not wait for 2 clicks. Just at 1 click, you do the hanging drop test.
And the other thing is the movement of the instruments inside the abdomen, because there is hardly any space to move. So,
But
so
madam, it is a
then
very,
the handling of the is the amount of the length of the instrument outside the abdomen is also
yes.
pretty
So, madam,
larger.
you can consider using 28 centimeter instrument,
Pediatrics. Okay.
pediatric instrument. That is helpful.
And how much is the use of 5 telescope? Do you all recommend it over a 10 telescope, or mm, is the field
When
of
we
vision and everything similar in a
the
thin
field
patient?
of vision the field of vision is smaller in 5 mm. But if the BMI is like really like 15, 17, then 5 mm telescope is a useful thing. Like I typically use it for pyeloplasties, thin built adult pyeloplasties, otherwise in
Mhm.
pediatric patients.
Okay, okay. Yeah. Thanks.
Thank you. Siddharth?
Sir, so should we take questions now or from the audience or after some time, after the second lecture?
I think let us finish whatever laparoscopy has to do. Then 30
Okay.
minutes should be totally to Harshit, including his
Okay. So
question.
if anybody from the audience has a question, they can just type in the chat box and we will take up. Sir, I have a question for you that regarding the ergonomics and the fatigue, instrument handles are very important also. So what is your
Yes.
take on using what kind of instrument handles to reduce the fatigue? The picture that you showed about that, sir, with his muscle increase. So what about instrument
So
handles?
So I usually use the for a retracting instrument. I use the handle up technique when I'm doing the retraction. That means the finger bars are facing up, and I'm using a palmar grip for the instrument. So you can have the finger grip and the palmar grip. For retracting, you use the palmar grip. So that takes away the maximum pressure on your wrist. But if you are doing a reconstructive procedure, that then it might be a more difficult thing. Like if we talk about say pyeloplasty versus a nephrectomy you can use the palmar grip and the instrument turned up. But a pyeloplasty, might be slightly difficult to do that, though it is more ergonomic.
Okay, and what about the needle holder? So you prefer a pistol grip or a standard grip or the one with the ring?
So the one with the ring is most unergonomic in laparoscopy. Pistol grip is the most ergonomic, but sometimes you don't get the drive very well with the pistol grip.
The
So
rotation is
most
missing.
ergonomic, rotation is not very good.
Yeah.
So the easiest grip is pistol grip, but most effective grip is the palmar grip.
But sir, in the left hand, we can still use the pistol grip because it will
Yes,
prevent the compression at the thumb.
yes,
Okay,
I
sir.
agree that the pistol grip is most ergonomic.
And sir, about the foot paddles. So we tend to struggle to find foot paddles when we are using the. So what are your tips
Yeah.
on that?
So, see, it is inevitable that you use foot pedal because you are going to use at least hook or energized scissor in some part of the surgery. It is not that you are not going to use it at all, even when you are using modern energy sources. So the thing is that before you put in a first incision, just place that foot pedal, and when you're making the incision for the port, use the cautery with foot pedal so that the foot pedal will stay there. That time,
Okay.
don't use the finger operated thing. That if
Okay.
you set it up right, then it will stay there.
And sir, do you believe in putting a floor light so that the surgeon does not trip with the wires and with the foot paddles? Some people put one of the lights on the floor.
What I would do is I would just put the dimmest possible OT light on and just leave it at that. If that is not possible, one of the overhead
Okay.
lights push to a
Push
corner.
to one of the corners
That
of the for
Yeah.
the
So the
and
reflected light will help.
will help. Sir, it will maintain the darkness as well as allow the surgeon to see. The last
Yeah.
question from my side would be, sir, are these angles that you have just talked about different for, say, nephrectomy versus a pyeloplasty for
So
extirpative and
see,
reconstructive surgery?
so they should not be different for the surgeries. But what happens is that if you when your learning curve advances and you are doing the more and more reconstructive work, that time you want more intuitive movements rather than counterintuitive movements. And as you do more intuitive movements, the ports tend to get closer to each other. So, like typically, if you would say distance between two ports is 8 centimeter for a standard surgery, for a pyeloplasty, I wanted 7.5, then progressively 7. Or maybe just like if you count in terms of finger breadth, 4 finger breadth and 3.5 finger breadth. So I wanted a little lesser, three and a half finger breadth for a pyeloplasty. just because I want more the arms to be by the side of the chest, more by the side of the chest, so that I can work with more rotational and in and out movements.
And also the target of the changes, sir. Being nephrectomy, hilum is the target, whereas pyeloplasty, UPJ, which may be usually low lying and more medial, the target of our port. Do you keep it the same, or you change the baseball diamond as you talked about?
It's not the, but that it will, if you even if you put it with a baseball diamond, that summit of your two fingers should be at the level of PUJ in a pyloplast. You
Which
cannot
will
keep
be
it at the level
lower
of
than what is there for the nephrectomy, because nephrectomy, the hilum is usually higher up.
Surely.
So do you change the angle, or you almost keep the same? Because a lot of beginners struggle
So,
by putting the same ports for the.
so what I do is that I first put in the camera port for a pyeloplasty. I mark the PUJ. I do RGP for all the patients, and I mark the PUJ, and then first put the camera port, and then separate the camera port on both the sides by 7 centimeters at present. But then when I started out, I used to keep 4 finger width, which was 8 centimeters.
Which is
If you one good tip is that you keep the right hand slightly closer as compared to the left hand.
okay.
So that
And your
that helps.
cameraman usually stands flat for pyeloplasty.
Cephalad. For all surgeries, cephalad. So though it is a convention, this is not a gospel truth. But it seems to be more of more utility as compared to the camera driver standing gordon.
So one last tip for all the youngsters. So where should a ballpark figure, where should they put their camera port in a normal Indian male for doing an extirpative upper tract surgery, like for an effect?
Camera,
ballpark camera, central port of camera. Yes.
So I briefly I'll tell you how I do it, and then you can put it directly in front of the 11th rib pararectally, and you're done with it. But how I would do it is I would mark the midpoint of spino-umbilical line, which is the same as the mid-clavicular line. Draw this line and put a line perpendicular from the lower border of the umbilicus. The point at which these two perpendiculars meet should be my right hand port on the left side.
That will be right hand port.
Right hand port on the left side, and the left hand
sir?
port on the. So you put this port first. Now from this port you draw a straight line. Directly subcostally you put the left hand port. Now divide this into upper third and lower third. At this junction, you put the camera port, which is at the pararectal level. Why not equal parts? Because the area of intention is very big. The kidney is 12 centimeters and ureter is 10 centimeters. If you're doing the same thing for pyeloplasty, the philosophy will change. That is, you put the camera port first by marking the PUJ at the pararectal level and go 8 centimeters north and 8 centimeters south pararectally. I would like to keep all the ports in a straighter line for a pyeloplasty and triangulate them for an extraoperative surgery.
So we move medially for pyeloplasty and make the angles more wider for as you told. Yeah. So any other person who has a question from the audience? Or Dr. Harshit or ma'am has any other question?
No, I think that was a fantastic discussion, especially regarding the camera port placement regarding nephrectomy, which most people suffer in the initial years. Thank you, Dr. Yadav, for raising such pertinent questions, and Dr. Abhishek Singh for a fantastic talk. My job becomes very easy after he talks so extensively about the ergonomics. So,
and I will also take this opportunity that sir has already designed a laparoscopy course in the upcoming YU, and all those who are attending would immensely benefit. Please do come and attend sir's course.
I was supposed to attend this YU very often, but because of my wife having exam, I'm not able to attend. I feel so apologetic at this time. So yeah.
Sir, so if with your permission, can we move to the next?
Please let us proceed to Harshit's talk. Yeah.
Dr. Harshit, can we have a talk? Please?
Can you guys see my screen?
Yes, Dr. Harshit, please go ahead. Yeah.
So first of all, thank you YU, thank you USI ma'am, Dr. Abhishek Singh, for having me here today on this, very important topics on ergonomics and robotic surgery. So as robotics is, easily getting available, more and more people are getting learned with robotics. They often, don't, give value to this particular thing because they're always very happy that they're sitting this time instead of laparoscopy standing. So with this, So I have predominantly used, my disclosure would be I am a predominantly Da Vinci Xi certified surgeon, predominantly use Da Vinci Xi in my practice. And before I go, already ergonomic stress has been laid by Dr. Abhishek, but I'll just share a quick story. So this was one of the very famous, Boeing B-17 was basically an aircraft which was used by America in World War II. And it was a very powerful aircraft, very aesthetic design. It used to go on, fire 20, 25 bombs at one time, was, a massive disaster for the German army and German troops. And so they literally named as Flying Fortress because, they would, it would do just fantastic job. But what was used to happen after doing such a phenomenal job, when it used to land back in United States, it used to crash. And that was like, everyone said was the pilot is so tired after doing a fantastic job. And so he's doing such, embarrassing and fatal accidents, such a fantastic aircraft doing great job, but, never able to land nicely. And the pilot often used to collapse or, die or, get severe injuries. And so it was always called the pilot error until, two young guys who were psychologists working in the, California, Alfonso Chapnis and Paul Fitz. They were basically veteran affairs hospital they were working in. And they said, okay, they asked, interviewing, starting it with the pilots who were saved. Like, what happened? Why did you crash? You did such a perfect job. You were, excellent in your job. And then what they realized is a simple thing that there were two gears which were identical and side by side. And one was used to do landing and the other one is used to fly the plane. And, they were very happy returning to the, to their home, and they would not realize and they would just press the wrong gear, and that would just lead to the accident. And that was such a simple basic error. And after that only, the aeronautic industry changed and they designed the knobs with various various tactile feel, so that the pilots gets, okay, this is my landing gear, this is my flying gear, and all that. And so they were also called, there are a lot of founding fathers of ergonomics if you see the Google, but they're also one of the founding fathers of principles of ergonomics in the industry. And so the key is you design the machines to accommodate human behavior instead of retraining human behavior to fit the machines. So what is happening is the industry says, you do learn, like, no, the industry should modify so as to, give comfort to the surgeon. So, when we talk of ergonomics, we think, yes, we kind of know it, but maybe not. And already, told by Dr. Abhishek that what is ergonomics, it's basically a study of interface between man and the machine. We'll talk mainly of the physical ergonomics here. And so this was a photo I took from Facebook about, 2 months back. So he's one of the very, one of the young surgeons who just got the Da Vinci, the centers in North India. And he posted a Facebook, that we did robotic cystectomy and cunt. You did a fantastic job. And yes, you did an awesome job. But then it was something like this, because it is not ergonomically sustainable. You're trying to fit in the things which, your body doesn't support and doesn't support the longevity. And so the problem is that we don't understand the problem. We always are ready to adapt to the environment, and we are not ready to change the environment to our comfort. We think that it is a part of our job. And of course, as the discussion has been happened with open and lab, with the robotics coming in, they say that, yes, you might have better ergonomics, which is not wrong, because we all know the advantages of robotics here. That is, motion, scaling, reduction, dexterity, improved freedom. The most important thing ergonomically is you're sitting. So when you're sitting, you're not wearing your weight. And that is one of the key things in ergonomics, that, it's a static load. Second thing is that you have an adjustable stereo viewer. So you have, your visual motor axis, which Dr. Abhishek highlighted already, that it is in your hands now. It is not an assistant who is showing the camera and zooming in, zooming out. So robotics has been shown to be superior when we talk of the pain in the arms and the shoulders compared to laparoscopy, which is very understandable. But it is still not, a golden thing that when you still, this is a big survey, I think from the Hopkins, we all know, I think Mohammed Alaf, who is pretty active in robotic surgery there. So 56% of the surgeons in total had physical symptoms. And this time it was not shoulder per se, but was neck and finger fatigue, which is the major component of the pain after the robotic surgery. And as urology is the key, branch doing the robotic surgery, so urologists were at the maximum stress. So finally, we realized that we have a problem. And so how was the, we already Dr. Abhishek told how laparoscopic ergonomics were set in, but for robotics, it was very new thing when it came in. And so they said, who is the one who is doing the job sitting? And that was pathologist. So the ergonomics of robotic console were primarily derived from the cytopathologist manual. And they're very simple. I think this is the key slide here. I think with this one slide, I should be able to tell you most of the things. So of course, we are not live. Generally, I do a live demo on the stage. How do you sit on the console? But mostly what we should do, that we should not hyperflex our neck or we should not hyperextend our neck. So the flexion angle should be less than 30 degree. That is the first thing. Second, your shoulders should not be abducted and they should lie close to your chest and they should not be super extended. So the flexion should be 90 to 120 degree and your knees should be flexed slightly more than 90 to 120 degree. Although, I don't want you to learn these things per se, but when you're sitting, just make yourself comfortable and that makes you ergonomically okay. So the shoulder abduction, as you know, in laparoscopy also, don't shrug your shoulders, don't elevate your shoulders. So shoulder abduction should be limited. You have a very good working envelope and you have clutch buttons so that you can always work in that vertical envelope. So make use of frequent clutching. That is what, that helps you to go ergonomically sound. Now, this is one position I would ask, I don't know whether they can see in chat. So this is one guy who is doing robotic surgery and, in anyone in the house can comment, like, are they happy with the ergonomic of this guy? Anyone in the chat box who can comment. Similarly, this is the another, same guy or the different guy who is sitting on the console. And, these two figures clearly demonstrate the first one, it is hyper flexed. And the second one is hyperextended. So we are not at all happy with this guy. However, but when we see this guy, it is almost, 15 less than 30 degree. His back is straight. So, you always, there is nothing, you cannot achieve perfect ergonomics at the same time always. But you should be aware of your ergonomics. And that is what is the key here. This was the paper from Netherlands. They tried to assess the angles, very, scientific, the mathematical paper. But what they basically said, that what are the harmful angles or which surgeons were doing, they were out of their safe zone. This was the trunk, neck, and then shoulder in some of them. So what is the optimal height? So, we have a Da Vinci console as we're talking for this talk per se. And so there are some limitations. The viewer angle is 40 to 60 degree. Viewer height is, fly and armrest is 74 to 84 centimeter. And when you draw these mathematical calculations, basically, the surgeon's height should be between 163 to 185 centimeters. So when the Da Vinci till the XI has been designed, it is optimal for the surgeon's height of 163, which is roughly, 5 feet, 4 inches to up to, 6 feet, 2 inches. So if you are shorter, especially, many Asian females, when they're working in states or, even in Asian subcontinent, versus when you're very tall surgeon, especially, many of the Caucasian and African American populations, so they have to suffer either at the leg end or at the neck end. And so that is the limitation of the console we have. And the Da Vinci has come up with the solution for this, wherein they have got the Da Vinci 5th generation, which is, a lot of ergonomic design. I don't know how many of you are aware of this, but it has got, of course, the force feedback or some tactile sensation, which is, which is, sort of revolutionizing in the field of robotics per se. Second thing is the surgeon console. So the surgeon console is basically, you can move the headset around and let me show you in the video that how you can, you see, so you can bring the console with you and you can sit comfortably as you want. And that is the beauty of the Da Vinci Si5. So it removes all of your limitations which you are having because of your height. And of course, then there is an insufflator incorporated in the vision tower. Then we talk about the chair. So now Da Vinci particularly partnered with, or the Intuitive partnered with the Nightingale company to make the chairs. We don't normally have this chair in Indian setup. When I was in States during my fellowship, we were having this chair in the OR. So it's basically, highly resilient foam with an aluminum base for durability, and all of it's ergonomically designed as per the console. But we still, the concept is that it should be straight, it should be movable up and down, and it should allow the surgeon to rest his hands easily or arms on the armrest. Then we come to the visual ergonomics. So there's been some few papers, which have talked about the visual ergonomics in detail, because when you are on the console sitting, constantly, there is something called visual fatigue or dry eye. And then we have got a lot of angles such as, vergence, accommodation mismatch, perception mismatch, vestibular mismatch. And we'll not go into these, details. But what we want to, discuss here is the distance open console versus closed console, which is, an endless debate right now. So when you have an open console, everyone knows, you're not looking in a closed chamber like thing. So you have a better communication with the OR. You might have improved camera clue. It is, you have less reliance on the visual cues for haptic feedback. Some systems give haptic feedback per se. And it is slightly better because you are sitting straight, you are not bending your neck. So it is, slightly better for the spine. But it is not that open console is like, golden console, everything is good in that. Because many of the consoles require 3D glasses to be worn, especially like SSA Mantra we have. It slightly, decrease the brightness of the operating field. You need to see horizontally now. So, it's not that you're not, you still need a very horizontal gaze. There is a thought process that it might have less stereopsis, and it can also cause more visual fatigue. Some of the studies are saying. So this is, an endless debate. We'll not go into this debate, but we should know that there is, open console versus closed console, and both have, ergonomics advantages and disadvantages. Then there are certain surgical systems like Senhance, which are controlling your eye movements through infrared eye tracking. Both, versus Senhance try to offer some haptic feedback. And, Hugo system has two different screens. One is, for head tracking, and one you can control that, cautery and all the displays. Second part, which no one, very few people or hardly anyone talks about, is ergonomics of bedside assistant. He's tried to, he's taken for granted that whoever is sitting on the bedside, do whatever, the surgeon is shouting and he doesn't know. And, when I always tell people, laparoscopy versus robotics, what is so different? And because a lot of senior people switch from laparoscopy to robotics. So in laparoscopy, yes, assistant assists you because he's there with you, he's seeing you, your hand movements, everything. But in robotics, you have to learn to take the assistance. That is the key in robotic. The console surgeon has to take the assistant, and it's not the assistant who has to give the assistance. And when this was a survey and they say, yes, 73% were in uncomfortable position, 20% have even pain or bruising due to robotic arms, an average of 2.8 obstructions per procedure were happening, especially, your forearm is there, so hitting the lower arm and the forearm. And tissue traction, we are asking him to grasp and hold, so that it doesn't slip. So the principle of ergonomics for bedside assistant, number one, follow Dr. Abhishek's advice. Follow good principles of laparoscopy, and that is the key. Follow all the principles of laparoscopy. Second, which a lot of surgeons would not know, and I want you to emphasize and see, will not go into detail, but there are something called arm clearances or patient clearance controls on each arm. What they do, they spread out the arms and give the space to the assistant. Third, when you are operating as a console surgeon, go smooth, go calm, don't panic. You have to talk to your, assistant, ask him why you're not able to assist, what is hindering you. Many a times your assistant port is on the right side and you have a scissor on the right side and you're doing a pelvic surgery. I'm telling you, all the young surgeons, if you're doing first robotic assist pelvic surgery with your surgeon, chief surgeon, it's going to nightmare. It is difficult to assist. So don't worry if you're getting a lot of scolding. It is difficult to assist. So many a times you go with your assistant port suction or something and you keep hitting the, the scissor arm, or you don't get the space to go in. Just request your console surgeon. Tell him, inform him that, sir, I need you to move. And the surgeon needs to understand that if he's coming from this way, how he has to move his arm so that he gets the space. So now, quickly we know the problem. We understand it better now. So what is this? First thing is awareness. The key is awareness. Second is you have some sort of fitness, exercise. And the third thing is micro breaks. So key role is, embark early. And that is the purpose of this webinar and YU has taken. And I'm so happy that YU and ISU has taken up this particular topic to talk to our young colleagues. So, there's a lot of guides, surgical ergonomics for urologists. So just know it. You can't be perfect. Just know it that, okay, this is the way I should do it. And gradually it becomes a part of your activity. You should have a core strength training, physical training. I was in States, one of my professors was yoga teacher, and we used to do yoga every alternate week on Sunday mornings. Sometimes my wife used to be very angry, you're leaving Sunday mornings, but it gives you strength and, for a sustainable career. And the last thing is the targeted stretching micro breaks. So what is essentially means, don't, get complex with this thing. So, how, I will ask, anyone want to answer that, the famous question that, how does a surgeon, everyone gets fatigue. So what is the best way of a surgeon to get, take a break? Anyone wants to answer? Any guess, Dr. Abhishek Singh? Like if you want to take a break and you don't want anyone to know that, you are tired or exhausted, what would you do in the operating room?
Take a loo break.
Eh?
Take a loo break.
No, take a loo is okay. You can't go. So the surgeons have a mentality. You ask for an instrument that is not on the operating table. And let the nurses struggle around. And that gives you time to, relax. That is, your subconscious mind way is working. That you ask something which is not on the table. You might need it, not need it, but that is one. So you should take. There's no harm in taking not a break. Okay. And so the what our recommendations are like, you should every 40 minutes, 30, 40 minutes you should take a break for 2 minutes. You can, we always do it. It's not that, especially when you're doing robotic cystectomy, a procedure like which is longer, you should target your muscles, shoulders, neck, and you should take a break. They have given a subset of exercise also, it's not like dancing in OR, but you move all your joints so that they are not in a state of constant contraction. And so, with that, so these are the three things, take breaks, get yourself aware, do some, strength training, physical exercise. And that is the key here when you're doing robotic ergonomics, that, just be aware of these angles little bit. And mostly when you do it, you will get yourself understand, that this is being strained. So, and I know this is my last slide, I think. We have got a lot of new systems. We have not discussed the ergonomics per se, but the grossly the difference is the console and, using of the 3D glasses in some of them. But ergonomics is, as we said, is very important. And as you are getting your career in the robotic surgery started, just get yourself right on the track, and that will help you make a sustainable surgeon. I think thank you USI, ISU, and YU for having me. And I'm happy to take any questions here.
Thank you, Dr. Harshit, for such a nice presentation. Ma'am, would you want to take a question?
Actually, I'm not a robotic surgeon, so I'm not the right person to ask him questions. But I do get a lot of leg pain while doing a laparoscopic radical prostatectomy, because you're trying to stand towards the head end, and
It's getting on
you're pressing on the table and going as close as possible towards the so I instead of shoulder pain, I do get a lot of leg pain. So I think, are there any tips for it?
I think, ma'am, that's for laparoscopy per se, but like, we should stand weight bearing on both legs. So what we are doing, we are having, some sort of energy control in our one of our legs. So we are standing obliquely, resting our whole weight on one leg and with the heel of
Yeah,
the
right,
second.
right.
Yeah. And so the
Yeah.
whole of the body's, weight is getting transmitted unequally towards one leg, and we are standing on the heel of the other leg. And that is what it is. And that's why, I think Dr. Siddharth already asked about the foot pedal use per se. Ergonomically, they say that foot pedal use is not that superior. You should try to have as many control in the hand. And that is what Liger Shores and all harmonics are coming in right now, even in Seal. So, and you try to, and just take breaks in between when you have this, and keep correcting.
Yeah,
My chair, we were talking about ergonomics, and the next day we were doing a surgery. It was, of course, open radical cystectomy on that day. So, so we are all correcting ourselves. My chair was standing on one head. It's not that, no one is perfect, but, keep correcting ourselves, and, get yourself assistant know that, okay, if I stand wrong, let me know. And with that, I think Dr. Abhishek can add on what he wants to thinks about this.
yeah.
So whatever you do when you're doing pelvic laparoscopy, it is inevitable that you will get your
That's
ergonomics not
bad.
perfect. I think every time just reviewing is the best idea, because it is very difficult to maintain ergonomic. Every time you can focus your ergonomics to a particular point. Here you are working with not three, four ports. Sometimes you get into your assistant's role, use the suction, it becomes very difficult for pelvic surgeries,
Yeah.
for pelvic surgeries.
And that's why I think that's a very difficult. Laparoscope pelvis are very challenging.
Yeah.
And we totally agree with you that it is a painful, demeanor. And
Harshit, what challenge that I face is that I get lot of palm cramps, lot
yeah,
of palm cramps,
that is
especially
that
after
is
neobladders. 2 days I am struggling.
the same question everyone asks me. Whenever I gave this talk in University of Texas Health, 1 year back in ergonomics, and so there are a lot of things on this. So when if you're in Da Vinci console, which I'm assuming you are, so when you put your fingers in that pincer grasp thing, so how do you engage your middle phalanx over that, or do you allow your just distal phalanx to be involved in that?
I use my distal phalanx.
Yeah, so
Distal
that is
phalanx,
it.
not
That is good. Yeah, so that decreases the pain. You are ergonomic experts, so you do it right unconsciously as well. So, you should, a lot of people would, they try to fit in the full thing in your fingers. And that when they move, that decreases the maneuverability. And when they move, particularly doing neoplatters and all that thing, you are actually doing a lot of pain to your fingers and the palm. So that is one thing that should be typically avoided when you're doing, long surgeries. Number two, what you should try to give rest at least your ulnar nerve and your radial ulnar nerve is particularly at your, elbow region. So always make sure that you are in your working envelope and your arms are always resting on that, that pad. Many times when you're fluttering, especially neobladder, when you're, moving around, taking the sutures, so you forget that thing, and that makes your nerves under neuropraxia or something like that because of your these type of movements. And number three, what I that was my personal experience. So I'm not sure how it works, but I got my vitamin B12 checked personally, and that was hard. A lot of times these neural problems are sometimes because of deficiencies of these vitamins. It's totally my opinion, nothing like evidence based per se. But I got myself injections of vitamin B12, and that showed remarkable improvement in my all these things. My hand used to sleep, and that there is sensation, that numbing sensation. So all these things are there, but yes, neobladder is a very challenging surgery for ergonomics of robotics per se. I
Yeah.
don't know.
another
What
another
is your
suggestion is that when you're starting out your robotic career, Dr. Omar Karim, who's a very popular proctor from the UK, taught us this technique that you should, with a crepe bandage, you should tie your hands loosely to the ergonomic pod or the central pod, the armrests of the Da Vinci system.
Yeah, so that is, you should keep,
So that
there
is
is a way of, so it is, when you teach children, in class one or two, either you teach them by punishment or you teach them by
yeah.
reward. So this is by punishment, you are tying them, you're restraining them, and this is all negative feedback. So it is an old school of, teaching that, you try that. But you
I
remember
think
that, you have to revise. So then you review always, there is no surgeon I can guarantee that who never lifts off his hands from the armrest. There's no surgeon I can guarantee that. But
I
even
think
one of my persons there, he used to fly in when he used to make this bladder, he used to climbing in, in the working envelope. But then you just keep revisiting and revising. And with that, I think you get,
the better way is to start with shorter surgeries, not with
yeah,
neobladder, which takes a lot of time.
never
And
start with a neobladder. Even I don't do neobladders. Very frankly, I don't do intracameral neobladders at present, maximum conduit. So I think,
yeah,
yeah.
one more question, Dr. Harshit, regarding the newer consoles that are coming in. So Da Vinci has a pincer grip, and the newer things have a pistol grip, right? So they are more ergonomic as per their the manufacturers. They are more ergonomic. What is your take on that?
So it's a difficult thing. I use SSA mantra, a couple of times, in conferences there. I actually found it difficult. That's because I got used to it with the pincer. But they say, so there is a different thing. Either your thumb is in the stress or your fingers are in the stress. That is the thing. In the newer consoles, you are basically moving your thumb up and down to grasp the instruments and move around. While in the pencil, your distal phalanx, middle phalanx is under strain because your thumb is pretty normally straight, and you move your fingers across that pencil grasp. So either of the fingers has to take an insult. So yes, industry, as per the industry, they say because you are in constant state of flexion, and anatomically our hands are like we are in the anatomical position is like we are in extension. So that supports the newer consoles, but it is more of comfort per se. It is not that, because even then you are moving, flexing your thumb, and if you're doing a constant movement, then you might remain in a flex situation. So these are open console, closed console. These two graphs, these are all very debatable issues at present. We don't have any common
And
consensus.
would you
Uh,
recommend a stool or a chair for the ergonomics for the surgeon?
Sorry,
Stool versus a chair
we always use
for
a
the
chair.
operating
I'm not
surgeon.
sure anyone uses a stool for the robotic.
People,
I'm not sure anyone uses a stool. You have
All
got
the
a
images
bag
people
that
with your
use
you
chair.
stool, but I think chair is better. People do use
all the
stool.
images that you showed actually had a stool. Because you're not supposed to touch the back to the chair. Okay.
Yeah, they
It's
were so, but they can relax. So that's another. So two things I missed. So one more
okay.
thing. So you have a forehead pad, and a lot
Yes.
of people think that you should completely, it should be in complete contact with your forehead. So it is for the rest of your forehead. It is not like that, like a robot that you are going to completely touch your forehead. It is for a rest. It is not that your forehead has to be complete. So a lot of people when they're starting in a console, they try to put, and if, even me, let me. So I used to try to make the whole pad touch on, so that's how I get the best ergonomics. And at that time I got so much of neck strain because I was flexing so much, but that is not the case. It is a sensor and two rest. So all the young friends, please do understand that thing. Chair, your back should be straight. So now a lot of things depend, on this console. So when this chair should be mobile enough that your chair should slide, your knee should be able to lie below your armrest. And when you are lying straight, your console should be at that particular angle with your eyes. And if at that time you should try, your back should be straight. And these chairs are designed like this, ergonomically. I'm not sure how many ORs have all these chairs in India because Da Vinci doesn't supply these chairs. But in United States, it is in their contract. So they will give this chair automatically when you buy this Da Vinci with them.
Oh. It was interesting. I think we all of us need to get our B12 and D, vitamin D and magnesium levels once in a while, because we hardly go out and we are always in the AC from morning to evening, and no exposure to
And
forget
especially
diet.
with
Diet is another
compulsory.
issue. Yeah. Anyway, thank you very much, Dr. Harshit and Dr. Siddharth and Abhishek. And it's totally new topic. And I'm sure there will be lots of hits and people would like to benefit from learning from both of you. And I also thank your involvement as YOU, and all the best for your upcoming conference. So if there are no more questions, I think we'll call it a night.
Yes,
Sure,
madam.
ma'am.
Thank
Yeah,
you very
sure.
much, madam. Thank you for
Thank
encouraging
you.
the youth of USI. Thank you very much, madam.
Yeah,
Thank you.
sure. Thanks.
Thank
Good
you.
night. Good night. Good night, everyone. Bye.